I would like to present our experience about liver venous deprivation. Do you know we are the pioneer in Europe, and especially with the mini-invasive surgery. So this is the plan of my presentation. Do you know very well, I think, the result of the portal vein embolization to optimize the future remnant liver? We have 20% of failure, 15% related to tumor progression, and 5% related to insufficient future remnant liver volume. What to do after PVA failure? Today we can do the embolization of the segment 4. We can do also ALPS, and in our centers we propose the liver venous deprivation. As you know, the hepatic vein embolization was proposed in 2009 by Professor Wang. He performed the hepatic vein embolization 2 weeks after the portal vein embolization with good result. And in our center in Montpellier in 2016, more than 5 years ago, our radiologist, Professor Gouillou, decided to perform the hepatic vein embolization and the PVE simultaneously with very good result. This is the physiopathology of the liver venous deprivation. Is the hypothesis proposed by Professor Colo. We have in a hyperarterialization of the sinusoidal space. So there are 4 steps in this technique. The first is the puncture of the right hepatic vein. We adopted in Montpellier the transhepatic approach. We have the second step, the portal vein embolization, glue and occlusion with a mixture between glue and lipidol. The third step is the occlusion of the hepatic vein with the alpha plus vascular plug, 75% oversizing. And finally, this is the last step, but I think the key point of this technique is the venous collateral occlusion after hepatic vein embolization. As you know very well, in this paper, you can see that in Budd-Chiari syndrome or in case of tumor occlusion of the hepatic vein, we have venous collateral formings between the different hepatic veins. So we know very well that we have in almost half percent of the patient, we have an intrahepatic venous collateral with the diameter less than 1 millimeter in 73% of the cases. But in case of tumor occlusion or Budd-Chiari syndrome, we have enlargement of this collateral. So the key of this technique is the occlusion of this collateral. This is the result of the literature about this technique in terms of volume. We have a positive result. Just one paper published 2 months ago from Germany. So we have the same result in terms of volume between LVD and PVE. In the other paper, we have more gain with LVD than PVE. So, but all these papers are discussing the volumetry. So we try in our center to try to assess also the future remnant liver function with the scintigraphy, with the mebrofenin scintigraphy. So we perform this assessment at postoperative days 7, 14, and 21. As you can see on the right, we have after liver venous deprivation, we have greater future remnant liver function than resection itself. We have almost 40% of future remnant liver function gain. So the results are very important. More important, the results are after that we called extended liver venous deprivation. So we perform the venous occlusion not only of the right hepatic vein, but also the middle hepatic vein. As you can see, we have a greater KGR, so we have almost 25 cc a day after extended liver venous deprivation. And if we perform a scintigraphy, as you can see, just after postoperative day 7, we have a sort of functional switch of the liver, especially of the futurament liver. So it's difficult to explain why. We try to perform a histological examination of the futurament liver of the liver with the metastasis. So we found a functional damage 2 times more important after liver venous deprivation than PVE. We don't know why, but these are the results. So to have a final conclusion, we need to wait our randomized control trial. This is national randomized control trial in France. We call HyperLive 01. We include the 12 centers in France, and today 64 patients were included. So I try to analyze the mini-invasive surgery impact in this 64 patients, including in HyperLive 01. So just a few slides just to show that the result of ALPS, you know that the major complication is death. And we have death after ALPS, also in patients with strict volumetric criteria, because this is the key point. We have not a good correlation, between volume and function. So in this paper we published last year, you can see that we have insufficient function and adequate volume in almost 10% of the cases, and we have adequate function and insufficient volume in 14% of the cases. This is the key of all futurament liver optimization technique. So, for example, in our center, we perform a major hepatectomy also in patients with insufficient volume, so less than 20%, but with good scintigraphy. So we try to analyze the difference of synthetic function between LVD and ALPS, and you can see the conclusion is we have less alteration of synthetic function after LVD. So last year in France, this is the patient where this is not randomized control trials. So it was a retrospective series of different cancers. So they include also cascade tumor, ACC, and metastasis. So they concluded that LVD, we have a successful rate of about 72.6% versus 19% of ALPS. So we have a faster hypertrophy with ALPS, but in this study we have different weakness, the selection bias. This technique was different, so it's not standardized. So this is the result after the liver venous deprivation. Just this slide to show that that is technically demanding and sometimes require 2 or 3 hours. If we discuss the mini-invasive surgery after this technique, we need to consider the parenchyma congestion related to hepatic vein occlusion, the difficult to realize the intraoperative ultrasound because we have the glue We have the vascular plug into the hepatic vein. So if we perform the intraoperative ultrasound, especially in laparoscopic, it's not easy. We considering also another parameter is if there is more bleeding related to parenchymal congestion, if the duration is longer than open access. We have more hepatic vein collaterals or not, so more bleeding. And also we need to consider the hepatic vein plugs position. So during the protocol, we decide to change the position of the hepatic vein plugs because in mini-invasive surgery, we need to use the endo-GIA. If the hepatic vein is close to hepatic vein vena cava, it's not easy to use this endo-GIA. So we decide to change the position of 2 centimeters to increase the possibility to realize the endo-GIA hepatic vein occlusion. So we decide to analyze our preliminary result in our HyperLive 01 trials. We decide to analyze different parameters about the mini-invasive surgery. So we have only 14 patients on 68 major hepatectomy performed laparoscopic. We have no case of robotic surgery. You know that in France we have more than 220 robots, but many HPB surgeons in France still do the major hepatectomy in laparoscopic manner. So we have in our series we have 14 patients performed laparoscopically, 7 in liver venous deprivation, and 7 in portal vein embolization, where all right hepatectomy. So we decide to analyze if there is some difference in terms of intraoperative bleeding, intraoperative transfusion, and operative duration. So as you can see, we have no difference between open and mini-invasive surgery between about intraoperative bleeding and intraoperative transfusion. However, we have a longer operative time with laparoscopic than in open techniques. As you can see, this is the history of the hepatic vein plug. We just modify the technique, so we can close the hepatic vein with the endo-GIA or also during the laparoscopic procedure. What about the oncological outcome? The same result in terms of overall and disease-free survival between mini-invasive surgery and open technique. So we have any difference between LVD and PVE. We have the same rate of post-hepatectomy liver failure, intraoperative bleeding, and bile-leaks. We have a longer operative time in a mini-invasive group. Maybe with the robot, the results are different, but in our HyperLive 01, only laparoscopic procedure were considered. And we have the same oncological result in terms of overalls and disease-free survival. We wait the result of our HyperLive 01 French randomized control trial, and do you know the international Dragon 1 international randomized control trial. In the secondary endpoint, we have also the surgical approach. This is my take-home message. The slide on the right shows the volumetry of the full remnant liver after post-operative day 7. On the right, the future remnant liver scintigraphy with the morphine at postoperative day 7. So liver venous deprivation is a valid and better alternative to portal vein embolization in our series of patients. We have 100% of success rate in a colorectal liver metastasis, and mini-invasive surgery is feasible also in patients underwent to liver venous deprivation. Thank you. You are welcome in Montpellier.
Thank you very much, Professor Panaro, for your excellent lecture. Is there any questions or comment? If there is a question, would you please raise your hand to ask question to Professor Panaro? Yeah, Professor Troisi, please.
Sorry, I just put my question on the chat line. I'm wondering what are the thoughts of Fabrizio Panaro regarding the minimal invasive approach following LVD. I will say, is the LVD minimal invasive liver surgery friendly approach? Because we know that after dual embolization, the liver gets congested and resection will be a little bit bloody. So I will ask him what he thinks about the preparation of LVD for laparoscopic or robotic second stage or first stage surgery by minimal invasive approach.
Thank you, Roberto, for this interesting. So we published a first paper in last year with Gianluca about the difference between LVD and PVE in open surgery. There are no differences. So the data that I showed today are from the national, our national registry, our randomized control trial. The hypothesis of this study that we have, as you said, we have more venous collateral between the hepatic vein after LVD because we have hepatic vein occlusion, and we just know that we have a longer time and we have a tendency of more bleeding, but is not significant because we have just 14 patients, so 7 patients in each arm. I think if we have more patients, I think we have more bleeding during a laparoscopic procedure. So in our center is a Professor Fabre that performed 5 cases, and we have more longer time because we need to better control this venous collateral after LVD. So I think with hepatic vein congestion we have more bleeding, and sometimes is a bleeding not easy to control laparoscopically. So we need to use the bipolar grasper every time, and sometimes with the clip or other devices is a little difficult to control. So in every time we use a Pringle technique, as you show in your segment 78. So we use a Pringle technique. We don't perform a continuous clamping in France. We perform intermittent clamping every 10 minutes, and I think it's feasible, but is a little bit more difficult during laparoscopic procedure.
Thank you very much, Professor Panaro.